I'm Dr. Mariani from CCRM in Northern Virginia. Maybe on your schedule it says Dr. Brian Levine. Clearly this is not me. He's from the New York office, and so CCRM, as I said in my introduction, stands for Colorado Center for Reproductive Medicine. We started in Denver 20 plus years ago by Dr. Schoolcraft, one of the pioneers in our field. And because the majority of patients coming to CCRM are from out of town, we've been in the meantime starting these network clinics throughout the United States. And this summer, Boston, New York, and San Francisco opened. There's one in New York, and several others throughout the United States. Again, I'm in Northern Virginia, in Tyson's Corner, right outside of DC. And this will be very informal. I'll just answer any questions that you have. If you want me to talk about something in particular, a specific part of the process, I just want you to gather as much information and get to know me and each other as much as possible, so we can make this a little bit easier. I know it's complicated, but it's been done before, and we can do it together. So just let me know if you have any questions. I can start talking about random things related to the process. Let me know what works best for you. Does anybody have any specific questions? Yes.
Sure. I've asked some of the other physicians that are here today about just various differences in the fertility, or the rates different clinics advertise.
Yes.
Like, from your experience, what are the biggest contributors to the differences in that?
Yeah, that is an excellent question, and actually it is. I'm glad you asked it. So I understand, this day and age, we're all driven by statistics, by the internet. You Google everything, right? I Googled men having babies before I got here so that I know where to get. So anyways, the majority of clinics in the United States report our statistics, fertility clinics. We report our statistics to a governing body called SARTS, Society for Assisted Reproductive Technology. So every year at the end of our cycles, for that year, we report how many patients came through, how many retrievals we did of eggs, how many patients got pregnant. And then you can go online and check out those rates and compare me to clinic B and say, oh, she has lower rates, I'm going to go to the other clinic. There is a little bit of a problem with the reporting process, and this we recognize as a body of physicians in general. The problem is the following. Traditional IVF, regardless of who's doing it for what reasons, was that the eggs would be retrieved from the egg provider. They would then be mixed with sperm, make embryos, and an embryo would be placed back into the uterus of the woman through. This is all done in one cycle, one treatment cycle. So then the success rate would be per retrieval, how many of these women that had an embryo transferred back got pregnant. In more recent years, for several years now, and again through some of the technology that was perfected at CCRM, we've been doing genetic testing on some of these embryos. So we take the eggs out, mix them with sperm, we make embryos, we test the embryos, freeze the embryos in the meantime, and then next month, when A, I have more information on the chromosomes and the quality of the embryos, and B, the hormones of the woman who has gone through IVF have quieted down, and the environment in her uterus and her body in general is calmer and more conducive to implantation, I then transfer the embryo back. So even if I got all of my patients pregnant that way, it would appear that my success rate is 50%, because when I retrieved an egg, this woman didn't get pregnant. Then next month she got pregnant, but of course she didn't get pregnant because I didn't transfer anything back. So in the more up-to-date, modern clinics, and until our governing body has figured out a smart way to report statistics to reflect that change, it appears as if our fresh embryo transfer success rates are lower than they really are, because the statistics do not reflect what is really happening in clinical practice. I hope I didn't confuse you, but anyways. So once you now have these statistics, can you trust them? I would not just, as in anything on the internet, of course, I wouldn't just take these statistics in a vacuum and try to interpret them. I would talk to your clinic, and I wouldn't use them as a single. I know, for example, our statistics are above national average consistently, but if you were to look at sometimes I look at them and I'm like, whoa, I didn't think our statistics were that poor, because if you look at them the wrong way, then it can be misleading. So talk to your physician about your specific, who you are closer to in terms of a statistic when you're looking at these numbers. So a young woman with blocked tubes is not going to be the same as a 45-year-old woman who has very few eggs left. So you need to see what category of patients you are closer to when you interpret these results. So definitely take them with a huge grain of salt. Yeah.
If we have a known surrogate,
Yes.
does your clinic require us to work with an agency, or do we not have to? Or do you call
So, in general, clinics should use an agency for the surrogacy process, mostly for your protection. So it becomes very complicated legally, financially, ethically, socially, to coordinate all this just between your physician, who's actually has your best interest in mind, and then the surrogate, where there might be some conflicts of interest. And for us to try to coordinate everything, it's not in your best interest. So I think it's a good, first of all, so working with a reputable agency is great. Then bring in a couple of candidate surrogates to your physician, and then together as a team deciding if this is a person who indeed meets criteria. Because some agency might say, this is a great candidate, and I meet her and I say, I don't think so. She's had 5 C-sections. This will be her 6th. It's not a good idea. But in general, it is a good idea to use an agency, even if the surrogate is known to you, just to streamline and legitimize the process as much as possible, so so your interests are protected. Yes.
I was looking at the blurb here,
Yes.
and I see that you have locations throughout the United States,
yes.
but you also have a location in Toronto.
Correct.
How does that work? Would you be going to the clinic site here and working together with the Toronto side?
So it completely depends on each individual case. It depends on where the intended parents are located, where the surrogate is located, and sometimes where the donor is located. So it takes it's a little bit more of a, it's not a simple answer, you go there, she goes there. By having a center in Toronto, obviously these are Toronto-specific physicians that go there. I don't go to Toronto, I don't go to New York, I'm only in Northern Virginia. But if somebody was to become my patient, but their donor, or not their donor, their carrier was in Toronto, we could coordinate with a clinic there. But you would have one, and this goes for every clinic out there, not just CCRM, but you would have one designated provider in the clinic who will be responsible for the entire care, and then coordinating different pieces of the equation throughout the United States if you need to. I don't know if that answered your question completely.
It does.
Yeah? Okay. Other questions? Yes.
Are there standards for screening egg donors?
What are the standards?
Are there standards?
Yes, absolutely. Very strict standards, both for donors and for surrogates, of course. And for you who will be the sperm donors in this equation, or whoever it will be. The standards are guided by the FDA, so not only will the FDA have specific requirements in terms of risk factors, for behavior, for exposures, for the donor, for past medical history, genetic history, things that the FDA dictates, and of course my clinic and my clinical experience dictate. And then in addition to that, they need to undergo testing, and I of course meet the donors. If the donor were to say something funky to me during her interview and I didn't think she was appropriate, that would be a reason to exclude her. So we're extremely, for surrogates, for whenever in general, but especially when a third party is involved, we are extremely careful in terms of the acceptance rate is very, very low out of all the people that apply, because this is a complicated process and you need to make sure that everything is in order. But yes, there's an extremely strict process in terms of screening. So the majority of people don't even make it past the initial screening process, but once you do, there's still all these what do you call them, obstacles you have to go through to make sure that everything is in order. But absolutely, dictated by clinics and by the FDA. The FDA regulates all this. Yes?
How many times do you meet with the donor, surrogate, the IPs?
So it completely depends. If it's a fresh donor, I would be meeting with them during their cycle. If it's you're talking about me as the physician or you as the couple? Oh, okay. So if it's a fresh donor that I'm cycling, of course I will meet them ahead of time, and then I will be meeting them through the cycle, and then at the end to make sure everything went well. If it's a donor through an egg bank, I never meet them because the process has already happened, and the eggs have already been stored in the bank. The surrogate, I would meet ahead of time. We have a separate meeting, then we have a meeting with you, and this is not including the psychological screening. So as the physician, I would meet with them, then I would meet with them and her, and then, of course, I would follow her through the process. And by meeting, of course, we don't have to be in the same office. We can do Skype consultations, preferably not telephone conversations for everything, but Skype or FaceTime or whatever it is. So there's some sort of face-to-face interaction. Yes.
The frozen and fresh cycles, is there a major cost difference, and are the success rates different?
Yeah. So you're talking about eggs, correct?
Yes.
Yes. So there's two categories of egg donation. There is fresh and frozen. Of course, they all start with the same concept of a woman who's taken medications to stimulate her eggs, her ovaries to produce more eggs than she would have otherwise this month. And then we take all these eggs out, and we either use them fresh to mix them with sperm, make an embryo, transfer the embryo back, or we then, we'll call it 24 eggs that she produces, we're going to aliquot them into cohorts of 6 and freeze them. And then you come around and you say, I want one of these cohorts, you purchase it and it's yours, and then it comes to my clinic, or it's already in my clinic. I thaw the eggs, the 6 eggs only. I thaw them, I mix them with sperm, I make embryos, blah, blah, blah. So this is what a fresh and a frozen egg donation process means. In terms of cost, yes, there is a difference, because you're buying 6 eggs versus however many eggs a donor can produce, which for a young, successful, healthy donor should not just produce 6 eggs. She should be producing 10, 15, 20 eggs. So it's more affordable, it's more streamlined, because the eggs are there waiting for you. You don't have to worry about her not stimulating well, not showing up for her monitoring appointment, not doing well at the end of the cycle. However, the disadvantage, of course, is that you're getting 6 and not 26 eggs like you could have. And it goes back to my point of when I was talking to some of you, do you really need 20 eggs to have one baby? And what I tell all my patients is, if you know you're going to have, if you want to have 3, 4, 5 children, then you should not be doing the frozen egg approach. It's not going to get you there. But if you want one child, maybe with a prospect of a second in the future, the egg bank makes a lot of sense financially, in terms of the process being more streamlined.
And the success rate?
Oh, the success rates. Thank you. There was something else. So the success rates. So in the hands of, so there's 2 parameters in this. The downsides, where things can go wrong with a fresh cycle, is that she might, as I was saying, she might not be available. She might be in school and finishing up a semester for a couple more months. She might not respond as well as I thought she was going to, because I don't know what is going to happen in the future, right? Or her eggs, she might respond well, but her eggs might not be of great quality and therefore don't have a whole lot to use, or they might not fertilize as well. So this is the disadvantages of the fresh cycle. But of course, you're getting many more eggs, and clearly the majority of times there are no surprises, but I don't know who's going to have a surprise ahead of time. The frozen cycles, the potential issues are that she might not, I lost my train of thought for a minute. You were asking me about success rates, right? So for the frozen cycle, she might not, I'm so sorry. I think it's my lack of sugar. I haven't had anything to eat all day. I don't know what I was trying to say. Do you know, Susan, what I was trying to say? Anyways, bottom line is that these 6 eggs, it's possible that they will not. Success rates. Yes. So, right. So going back. Okay, rewind. So it's possible that it all depends on the egg bank where they came from. So how they were, the clinic, actually, they're not coming from an egg bank. They come from a clinic to the egg bank. So how she responded and how they were frozen. So it has to be a bank that I trust in, that they froze good quality eggs and in a way that I can thaw them efficiently. And then it depends on me being able to thaw the eggs efficiently. And therefore, again, I know in my hands what the success rates will be, and a good enough reputable clinic should have no problem thawing frozen eggs, and therefore your decision should never have to come from frozen eggs are less successful than fresh eggs. This is not the case. They do extremely well. So it's only a logistical, financial otherwise decision, not based on success rates. Fresh and frozen eggs do exactly the same. Of course, you could, the survival rate of a frozen egg when you thaw it is upwards of 90%. So there shouldn't be a problem, excuse me. And a lot of the banks have a guarantee process where if you do not have a good quality embryo to transfer back at the end of the cycle, they will give you another cohort for free. They'll refund you something. So there is this additional guarantee because they feel so confident in the quality of their eggs. Sorry.
No, you stated that the frozen egg option is best for if you wanted one child, maybe with the possibility of 2 down the line. What would be the best option if you wanted to do the dual embryo? Like
transfer?
Transfer of twins.
Yeah.
Would you choose the fresh or the frozen?
Yeah, so my mean self will come out, and I do not do electively double embryo transfers, and you should think twice about doing this. So yes, I understand it's more efficient in terms of cost. You're transferring 2 and you're doing this once and you get twins, but twins are a high-risk pregnancy. So you are, first of all, having someone else go through this high-risk potentially experience for you, right? And it's the risk of the mother and the risk of to the babies in terms of then being them. Oh, thank you. You're like an FBI agent. I am wanted, yes. So it's risk of twins. Thank you. Yes, without sugar I can't function. So yes, so the risk of a miscarriage, the risk of the baby being born premature and not making it, of the babies being born premature and having severe disabilities. So this is not a good idea to plan for it. Trust me, I know this is moving your whole world upside down, but it is not a good idea. So I will not electively transfer good quality eggs coming from a donor who has good prognosis into a surrogate, electively transfer 2 of them. And it is what most self-respecting great doctors out there will do for your protection and the protection of the donor, of the carrier, I'm sorry. In terms of, and again, going back to the number, so the number 6 or 7 and 8 for the cohort of eggs is not a random number we pulled from the air. It's a number that so once you start with a group of eggs, then not all of them will fertilize. About 80% of them, 75, 80, 85% of them will fertilize. Out of those, maybe 80% will make it to day 5 to be transferred back as embryos. So looking back at this, and then not all of them will have normal chromosomes and have a chance of implanting. So looking back at this attrition process, I need to figure out when do I get a good chance of an embryo being transferred? How many do I need to start with? If with these percentages, it boils down to 1, and that's how the numbers 6 or 7 and 8 came up. That's how it came about, and that's how it's based. Again, that's what I'm saying. So out of 6, you could potentially transfer 1 and she gets pregnant and delivers, and potentially you have another one to freeze as embryos I'm talking about for a future chance. But for sure, 1 is, it gives you a very good chance at 1. Yes.